This is the Situation Room, the only way to start your day.
That those people who are there to stand with you at all times, not only those that you are with during Mary, and then at the times that you have troubles, they leave you alone. Yes.
It's true. That's it. That when you know them, you know them for when they've been there for hard times as well as good.
Yeah.
All right. Let's look into, let's do an overview, if we can, as maybe one of the longest overviews that we might do of the medical situation in the country at the moment, Daktari, and what we're trying to look for to make it better. Every time we talk about things that need improvement, the health sector comes in. We talk education, we talk health, we talk health. And now there's a clinical officers strike. It's now into its 20th or so day. Nurses have always been up in arms. Doctors, it's back and forth. And now that we're dealing with entrenching foreign doctors into the medical sphere responsibly, let's start with an overview of what the health sector looks like at the moment.
Basically, it has always been a concern that we all aspire to have a universal health access, that we want Kenyans to be able to access healthcare devoid of their socioeconomic status. And the narrative goes on very well despite all the conversation that we have. But one thing that we always see to be a challenge is the investment, or the financial investment in healthcare, that makes the county, the national government do not employ healthcare workers, or the agreements that have been put in place, some of them have not been honored. That's why you'll see clinical officers on strike. They're on strike because the Ministry of Health, they have agreed on a CBA, which the ministry say if they sign, it'll only cover 150. For county or 47 counties, they've not had any agreement. So you see that then becomes a strike and a disagreement. We have things that concern nurses. So it's always a space that... and this happens strongly after devolution. It's part of a lot of chaos and a lot of disagreement. When you agree with ministry and everything in line, you realize things are pending with counties. When you agree with counties and all these matters, things still have to pen on this other side. So that's why there seem to be elements of chaos in it. But the last pronouncement on the issues of foreign doctors, I think as a country, we need doctors. Kenya needs over 50,000 doctors to reach the WHO ratio of 1 to 1,000. We have a ratio of 1 to almost 16,000 now, almost 1 to 17,000. And the reality is that most of the hospitals, public hospitals and private hospitals, have a shortage of doctors. At the same time, the country has been graduating about 1,000 to 1,300 doctors every year. But if you look at the numbers that are being employed from that graduation, when you look at the year 2025, you had about 600 doctors employed. When you look at the year 2024, we have about almost 800. So the absorption rate in employment, both in the public and private sector, is very low. And there's a skewed system that has been created by private sector. We have hospitals that are private sector that they operate within the country, but in their sole operations, they don't employ any local doctors. They go and get the foreign doctors into the hospitals. Once they have them in the hospitals, the problem is not having the foreign doctors. The problem is once they have them, they pay them lower wages. You realize that an Egyptian hospital is paying the doctors maybe 50% of what doctors are being paid in the public sector. An Indian-based hospital does the same. A Pakistani hospital is also doing the same. So as a union, we say that when that is done, then that becomes a modern-day slavery. It means you are encouraging slavery of this particular professional. That's one thing. And then those hospitals, once they have gotten what we call the cheap... they got cheap labor. That's by exploiting these doctors. And these doctors come from everywhere. There are those from Uganda, there are those from Tanzania, there are those from different places. Though if you're from East Africa, you are considered a local. But still, they go through these particular poor wages. That is the concern we raised as a union, that if the ministry is taking actions against these particular hospitals that are solidly specialized in getting doctors or healthcare workers from outside, just to exploit, it's not right. They should be paid dignified wages. And then in that process, the local doctors who have graduated, who have been employed, are then forced to do locums at 1/10 of the rate that has been prescribed by the KMPDC. You realize that the rate that a locum will be paid is always 2,000 per hour. But you find most hospitals will be giving 300 or 500. Those are the things that we are saying. You float the laws in all aspects. Then the other thing is in employment. Employments are not just, when you have a facility, whether it's a private facility and you run it, there are procedures for employment. You advertise, there's competency, and then you recruit the workers. So we were asking, what criteria are being used by these privately owned hospitals that are internationally owned in the country? Because you realize that we have the general practitioners in the country, maybe up to the tune of 2,500 or 3,000 unemployed. And then this, the law says, for you to get a permit D and to be employed in Kenya, the company or the employer must prove that they advertised and they could not find those particular local skills for them to import this. But then we have the same general practitioners who are unemployed, but then there are some that have been employed by these institutions at these particular bad terms.
And is it private institutions who are hiring these doctors?
Yeah, majority of them are in private institutions.
Okay.
Though at one point in the strike of 2024, even some county governments were crossing the borders to get these particular foreign doctors. It had been a reactionary thing that started during the 2016-2017 strike, where the government acted and brought the Cuban doctors to the country. Yeah. But you see, for the Cuban doctors, it was not just, they were not being, it was more of a government-to-government agreement. And in that process, yeah, it costed taxpayers a lot of money in the process. That's why even at the end of the day, the project could not be sustained.
Okay.
Yeah.
So what basis then did CS Duale use to, was this the basis then that CS Duale used to say Kenya first in terms of a policy and then revoke, I think it was 200 plus licenses of foreign doctors operating in the country, which was backed by KMPDU?
Before the CS revoked the licensing, we were trying to analyze, and I think I was at his office with, there was also, DG also was there, on the aspect of, is it just a matter of licensing? Because you may have many doctors licensed. For example, doctors who are doing postgraduate training in Kenya are licensed to study with the postgraduate training. And then it was looking at, if, for example, you look at these foreign-owned facilities which were asking for this licensing. I saw the DG came with a list of the doctors there. And this list, it means that they have their license and they have the work permit. And so which of these particular cadres or work were their availability in the country? And it was realized that almost 70% or 80% that list of those doctors were same doctors in the country who were looking for jobs. So that was one of the bases. The basis was that some of these hospitals are outrightly, either they are mission hospitals or they're private hospitals, they are deliberately not in any attempt are the local doctors, and they exclusively get the foreign doctors from the country where they originated, and therefore, in a way, they were floating the permit D. He realized that this had already been floated. Before these doctors were given permits, there was to be an expressive show that there is non-existence in the country. So the Director General and the Minister then decided that for those particular specialities that we don't have, then you're going to renew their licenses. But for those that we know exist, then it is important or it's imperative for these particular hospitals then to give opportunity to the Kenyans. That was the basis of the delay in the renewal of the license. But if you look at the statement, it did not say that they're not going to renew the licenses. It said that we have to give opportunity to these particular Kenyans that have actually graduated or have already completed these specialities. The other issue that came up in this particular conversation, it was a discussion that every year we have been fighting about the intern doctors, and the doctors are graduating every year. And the budget, I think, is about 10 billion. So yes, we have doctors going to school in the country. We have government sponsoring doctors to go for internship and graduating. And then a private hospital that operates within the same framework then decides not to give opportunity to these doctors within the same community. So that's one thing that we are trying to be skewed. And they're not doing it by following the law. They're not doing it by bypassing the law. Because you have a Pakistani facility that operates within the country, then you employ none of them, and then you are going to use these particular doctors in the country as visiting staff. It means that you are going to exploit them as locamers. So that is something that the operation of these hospitals in all its way have floated the labor laws from the employment, from the wages, and from the welfare of the doctors.
So, Dr. Another issue that came out clear was in terms of the patient risk. As well as safety. And the reason why this comes in is because, like you've just mentioned, there is the exploitation of foreign doctors in the sense that they come in, they're paid low wages, and that then goes to look at these facilities prioritizing profits and not patient safety. How critical, or what are some of the cases that you've seen, and just how critical is this and that Kenyans should know about?
By the time that you come as an employee in the country, and there are also cases whereby you are licensed and then you don't have the working permit. So because you are licensed and you're in the country, you don't have the working permit, the person holds, the employer holds all the rights. So you're actually like a slave for this particular employer. And that's why we had the organ transplant scandal that we had last time. In the investigation, it was very clear that majority of the perpetrator of the same were foreign doctors who came from India in that facility, because you have no right and you cannot be employed anywhere at this point. The second thing, we saw hospitals in Nairobi West, where what do? They have doctors imported down. You cannot question any content of your contract. So, in essence, you're a slave. In Eldoret, what were they doing? They bring doctors that then there's a way I think they used to do with the council, maybe backdoor and bribes and get these licenses. And once you have that, and also they do their back channeling with getting the permits, these doctors are put in the bus to hostels and back to the hospitals to work.
Every day.
These were the concerns that you're having. Then they live in the hostels. So to us, it doesn't matter where you come from. It is actually illegality. It contravenes the Kenyan labor law to have an employee engage in such a manner. It also contravenes the ILO Convention C-100, which stipulates very clearly that you cannot mistreat a worker who offers the same skill as the doctors locally. And we have seen that. And even if you live at those particular foreigners that their license were pending, the 200, we also have those who are considered local doctors like Tanzania, Uganda, and Burundi. What wages are these particular employers giving them? You realize that an employer will confidently sign a contract that pays these particular doctors a third of the wages. You pay them, and then those who are Kenyans, because they find that these ones have a right or know their rights, then they exclude. And therefore, they create a desperation scenario where then this one are only engaged on a casual basis. So that's what we union feel like it's not right. And therefore, we advocating that every doctor being employed, whether it's a foreign or local, should be given the dignity that they deserve.
Dr. There is law that ought to be followed. There are structures, even when it comes to employment of doctors in the country. No one is saying do not employ foreign doctors. But there is a systemic failure in terms of those who give the approvals and even the hospitals that bring these people in. They clearly know which buttons to press or which offices to go for these doctors to be in the country and to operate pretty much against the law. One then asks the question, who has failed the medical fraternity in this case?
The failure then becomes a multifaceted issue here, because, and this is one thing that I was asking, that there is a very direct or explicit regulation on the work permit, still permit D, that before you are issued these, you must demonstrate by all means that you advertise the positions transparently and that you could not find any local doctor or local person that can get these particular jobs. But then you realize that those are not advertised. And that's why we have a floated number of doctors that are not employed. Yet we have shortages both in the public facilities and the private facilities. But then the persons are being given a work permit. So again, these people also been licensed. So meaning there's some, I would say, oiling or action that were done from immigration point that brought these persons in, which is not a problem. The second part is now the aspect of licensing. So when the Ministry of Health, I believe, was acting on this matter, they were looking at it that why would it be that we have general medical officers in the country to the tunes of, let's say, even 300 or 500, when we have 2,000, 3,000 unemployed doctors in the same country? Does it mean that if you are having an hospital in the country, then you cannot follow the immigration laws? Does it mean that the licensing then doesn't apply to you? So to exercise this power, they then try to push back. Because ideally what should have happened is that the work permit should have not been there.
Okay.
Yes.
Dr. Just a series here. How many unemployed doctors does Kenya have at the moment? Qualified, unemployed?
Yeah, the numbers keep changing every year. I mean, we had, in the year 2021, we had about 4,000. And then we had progressive employment that took place in different counties.
Right.
Every year, I think between 600 to 800. But then the production that's every year has been about 1,000. So if we look at it now, we could be having about 2,500 unemployed doctors.
Okay.
And this year, by I think August, we have a release of 1,750 doctors being released from internship. So it means the numbers will keep on surging up to about 4,000, almost 5,000.
So at the end of this year, we could have 5,000 unemployed doctors.
Yeah, it's possible to have that.
You also talk about a shortage across hospitals across the country.
Yeah.
What are we talking about then in terms of a shortage?
In
terms of numbers?
The county or the devolved system has had a very poor way of employing doctors. As I told you, the ratio that we have, the WHO ratio of doctor to patient, ideally should be 1 to 1,000.
Yes.
But what we have is 1 to 17,000.
Yeah.
It means that the employment of doctors is necessary. If you go to any county, if you look at the population versus the number of doctors that they have, there's a big shortage. For example, you saw during the strike in Kiambu County last year, Kiambu employed 100 doctors.
Yeah.
But it doesn't mean that by employing 100 doctors, when the 300 doctors went back to work, there was success. There's still more for them to employ because they have a target to employ almost 700 doctors.
Okay.
So we have a shortage across the country.
Right.
And this is occasioned because of before the devolution, every doctor that graduated from the university between up to 2016 were directly absorbed into employment.
Okay.
Because there was a budget at the Ministry of Health that was destined for this. But then when health was devolved now into different counties, the county governments are saying, or they claim that they have reached the budget ceiling, and therefore they cannot afford to employ every year as much as they need.
Yes.
So every year we have doctors graduating, but you would find about 40 to 50% of them are the ones who get to employment, both in the public sector and the private sector. And that's what results into the employment. And that's why we keep on saying that for us to really solve the issue, because the shortage is there. The shortage is there to the point that if we look at the numbers that we produce now and employ all of them, it will take us between 30 to 50 years to actually reach the ratio that we expect to have.
Okay.
Yes.
Now,
so it means the shortage is there.
So there are unemployed doctors, problem number one. There's a shortage of doctors, which if you looked at it from maybe a bit of a basic eye, you would then be able to say, well, how about we take these unemployed doctors and put them where the shortage exists? But then we've also established that there is a budget problem and that ministry, which should employ, at some level, at least for the public hospitals, doesn't have enough money to hire them. That's what we've been told, right? Is that the problem?
Actually,
because it seems as though it seems like it's very clear, no brainer here. There's a shortage. There are unemployed doctors. Hire them and put them where there's a shortage, right?
Yeah.
Why can't we do that?
There's an issue here. I think in the bigger part of 2023, in our demonstrations and in our advocacy, we wanted the employment of the doctors. That was the major thing. And it led us into, I think, streets on 12th of September, where we then gave a petition to the then minister, Nakumicha. We proceeded then to go on strike in 2024.
Right.
And we signed an agreement with government that we wanted to have employment of 2,000 doctors to start in the year 2025, 2026, this financial year.
Yeah.
And then proceed to have annual recruitment of doctors. We had a meeting, I think, and this was in line with the Kenya Kwanza Manifesto, where they had promised to employ 12,000 health workers within 100 days. So we were looking at the request, the demands we had vis-a-vis their manifesto on implementation, and which now the employment of 2,000 doctors has been part of return to work formula and part of a court order. I think last week we had an engagement with the ministry, of which the CS, Duale, told us that he's working to ensure that there is employment of these 2,000 doctors, and he was going to discuss it with the president. But then there was a part here that these doctors are being employed to be employees of the county. So therefore, we must bring the Council of Governors on the table, whatever discussion, that under what framework will they be? Is it going to be a situation whereby the ministry is going to give money to the counties to employ, or is the ministry going to employ and then post them to counties? So there are intriguing issues that come in at a time of implementation. But for us right now, we're looking at that. Let the minister, national government, or treasury have the budget, and then now we discuss now with counties. How do we get this implemented?
Dr. For a very long time, there has been the push of a health commission.
Yes.
Right?
Yeah.
And one would ask, why not have a health commission that would just handle doctors' welfare, employment and absorption into the system? And that has been a problem for many, because then there are those who say it is the responsibility of the counties to hire. The national government has its hospitals to hire. Where are we with that conversation of health commission? And if it's not being implemented yet, what's the problem? Who's opposing it and why?
Those are some of the constraints that we have with this constitution. And I still believe that a centralized way of managing and handling healthcare workers will be of great value. And why am I saying this? Because if you look at the annual budget, 10% of this budget goes to the counties. And that's what the counties use. And in the course of the year, the controller of budget tells them that you've exceeded the PFM Act, whereby you cannot employ anymore to or pay more wages than the development. But then on the other side, if you have a centralized way, then there will be a distinct budget like we have for the teachers. There is the Teacher Service Commission has a budget that is directly aligned to the promotion of the teachers, employment, and all these issues with teachers. The same to the police, that the existence of the Police Service Commission gives this guarantee. And therefore, we still tend to believe that if we have Health Service Commission that have a different budget from the budget that is destined to the counties, then there will be an assurance that these given numbers of healthcare workers will be employed. And that's why even the manifesto of the president on employment of healthcare workers has not been implemented. Well, that on an employment of teachers and employment of the police has been implemented because of this particular issue. So still, as much as county governments or governors tend to believe and tend to say that by relinquishing the healthcare workers, they're going to lose autonomy and control, because they say if they cannot pay, then they cannot discipline, they cannot handle it. So that issue of ego sometimes go stronger than the issue of service delivery. The other issue that happens is that when the health workers are within the county domiciles, then some counties can then use these healthcare workers to do their businesses of having ghost workers and things like that. Because the idea is, even in the manifesto of Kenya Kwanza, one of the things that the president promised, that he was going to be a mediator of the issues of healthcare workers between the counties and the unions by ensuring that there was a health service commission. But I guess that after election, then governors came guns up and saying, no, this is something, it's our baby, is something we hold. But you realize that some progressive governors have come to realize that you don't have to hold on it so much. And that's why I think Jaramogi Oginga has been left to be level 6. And many counties are doing that. Like Mombasa, if cost also become a level 6, because counties or governors have realized that to run an healthcare, it just needs a PR.
Right.
It needs money. And when you have limited money in the counties, you'll have to need money from the treasury.
And with that in mind, fact that then some counties are relinquishing some hospitals to go back to the national government, is it about time that as a country we just had an honest conversation with regard to healthcare in the country, and we decide let this be a national government function, that let healthcare be handled from the national government, have a health commission where everything is being handled from a central place? Will that also help in terms of, because you find there has also been some talks in terms of there is this county that has decided, say, to bring doctors from outside to bridge the gap, right? There's this other county that is paying their staff on time as expected. If we decide to take this back to national government and have a commission, will we be heading towards finding a solution that is bedeviling the health sector?
So I believe that will give us a bigger solution in terms of the unrest and disagreement, this harmony that always occurs between the healthcare workers and the employers. If you look at even the year 2025, as KMPDU, we had about 21 strikes in 21 counties. It means that even as we speak today, the doctors in Nairobi are on the streets. Why? Because they have not received their salaries. They're concerned about their medical insurance. You see, these are concerns. When you look at the same thing up in quite a number of counties, like in Kajiado County, you realize that the statutory deductions for the last 6 months have not been remitted. So you get your salary, but even because loans have not been paid, you can't access the money because the bank takes everything. So these are a problem, the sporadic problems that occur in each and every county. Yes, there's some counties that tend to do so well in the activities or in the welfare of the workers, but it's quite sporadic. They will do well now and then they'll struggle tomorrow. And some counties also have gone into the overdraft, whereby because the money will delay from the treasury, then you do the overdraft to pay the workers. But this sometimes is net of the statutory deduction. And that's why even doctors had a problem with access to care. Many doctors, and I think even yesterday I got a call from a doctor from Garissa, where he has gone to the hospital with the son and he could not access the care. Why?
When you say cannot access care, what does that mean?
It means that your medical insurance is not working. The doctor's social health authority, which is a comprehensive cover, was not working. And the reason was the county government of Garissa had not remitted the deductions by 9th. And then SHA is made such that by 9th, if you have not remitted the premiums, then you can't access the care. So that has been affecting almost 70% of the counties. And I remember last December there was a discussion that the funds will be released to them by 3rd of every month, but that still doesn't work. So see, so it brings the concern. And why is it only specific to counties? Because our colleagues in the ministries are able to have everything, like their salaries paid on time. They're able to have their statutory deductions paid on time. They're able to have all these things sorted on time. Yet we have one centralized exchequer. So it means there's a problem with the exchequer or with the treasury aspect of it, but there's also a problem with the coordination or inefficiency between the national government and the county government.
Okay. Now, again, a series. Do we see an improvement in terms of equipment wherewithal in hospitals across the country? And I'm just dealing with public hospitals here, whether we're looking at levels from 2 to 6. Do we see that equipment and the staff required to run that equipment has improved? Are we doing better in 2026, coming in from 2025?
2026, we are almost approaching a political year, and therefore we are going to see a little bit of change from many of the governors and many of the people who have been in the leadership. Because you see, if you gave promises in 2022 and you're approaching 2027 and there are still public relations or PR on these matters, then it will be certain that you've not delivered.
Yep.
I will say that in terms of the brick and mortar, in terms of buildings and upgrading hospitals, the county governments have done very well in terms of building those facilities. You say this is a level 4 facility that has been built in this particular region and is able to offer this particular services that's outlined on the board. Yeah. The counties have done well in those buildings. But then you realize that when the minister came in and the KMPDC went down to investigate, and this I actually attribute to the leadership in the ministry, that is Dr. Luga and the CS and the KMPDC. One thing that came in is that now they're going to investigate these hospitals that are level 4, presumed, or level 3. They're all getting downgrades because then you realize that they're just a shell of buildings without ability to offer the services that they're destined to offer, because there's a number of doctors you ought to have in a level 4 hospitals that make it a level 4, that it's able to offer those particular services. You must have a theater space, you must have about 30 doctors, you must have the pharmacy that's operationalized, you must have the functional lab. So those then becomes the component that have been lacking in these hospitals. So yes, the construction is there, but then the service delivery is not there. So you will go to that hospital and you will not get the mixed skills of healthcare workers that you need to offer the services. And therefore you end up being referred. And sometimes you can be referred when the disease has progressed or worsened than expected, because you are not treated as expected at that particular point. So by the time you reach the KNH or the MTRH or the KUTRH, the level 6 hospitals, you are in a worse state.
Yes. Now, one of the things that we've been looking at over time is that if the people that we refer to, politicians, leadership, at that level, if them visiting these public facilities was insisted upon, that it would be a direct push towards the improvement of some of the things you talk about right now. That the brick and mortar would be greatly improved if there was legislation that insisted that you don't rush off to India if you have a problem that can be sorted out here. And I say this because we want to imagine that Kenya does not have the required personnel. And I beg to differ. I think Kenya, on the global map, has some of the best medical practitioners in the world. We have seen groundbreaking things being done at your level 6 hospitals here. You have doctors, medical practitioners who operate on a global world-class scale in facilities here. Do you think that it would improve the brick and mortar that you speak of if we insisted that people visit our local hospitals?
Yeah, for certainty, it is that, so for example, you asked me about the equipment. If I still delve into this, there have been different programs on equipment. The first one was it's called the MESS program that was there last time. Yeah, which actually was a mess in itself because, but it actually brought some changes in that there's so many hospitals across the country that do not have some equipment that are necessary. The IC equipment, the X-ray equipment, the diagnostic equipment, that then they could actually have this equipment. But the only problem that came out of the report from these particular equipments was that they lack the mixed skills of personnel to operate them. And some of them in some facilities were actually rusting. So, yes, that was one of the biggest concerns at that regular time. I know there's another program that the government has started recently on the same thing of equipment. But then we keep on saying that particular failures of the last equipments where there are no masked personnel should be avoided. And this can only be avoided by ensuring that we have the right personnel employed by the counties that help in operating these. I know that these ones are have a fully fledged operational technicians and everything, but still we must have healthcare workers in those hospitals to realize that these ones work. On your question of if the politicians or if the elected leaders then are forced by law to visit these particular facilities, I think there will be a difference. You know, most of the times we have somebody who is a baker. You bake bread,
right? And
you produce bread every single day, and you have clients or customers who buy the bread. And then when it's your time to take tea, you don't use this. You don't take the bread from your bakery. You decide to go and buy from your neighbor and eat the bread.
And then you have a bakery.
You say, no, my bread is good for consumption, but you don't use it. You will go and buy from your neighbors. That's what happens. You realize that governors are fully in charge of healthcare in the county. They decide, together with the MCAs and the county leadership, on what amount of money goes into the healthcare. The same to the members of parliament and the executive. They decide what budget do we put in this healthcare to run the country. But when it comes to accessing this healthcare, then they start thinking, is it really well baked that we can consume ourselves, or is meant for some other persons? So with that, then they will run or turn into PR stunts that we always see. That you say it's operational, it's okay, there's everything. But when it's for you to consume, you are afraid that maybe it has some toxins that...
So Doc, with just what we're talking about, do we have political goodwill that is intentional in addressing matters to do problems in the health sector? Why do I say that? Because there we just mentioned about level 4 hospitals that today are being downgraded because we do not have enough doctors to make those facilities be level 4s, right? We know that we have a shortage of doctors, but we have surplus of doctors who have not been, not surplus, we have doctors who have not been employed, that even if we decide to hire all of them 100% every year, we'll still not be able to achieve the numbers that we need. You look at the executive, members of parliament, you look at the governors, the MCAs, they do not consume services from public health facilities. Is there political goodwill in dealing with issues in the health sector?
You know, Dan, I've been privileged to serve with 4 ministers, four ministers of health in the country, and I've also seen this country when health becomes an agenda of the Big Four agenda during the regime of President Uhuru and the current regime, when universal healthcare is still a big agenda. So I've seen all this through this time. The times when most things were more political, that there was nothing destined to work. But I will give it almost 70 to the current team in the ministry. That is on Duale and Oluga, Mudoni, and the chair health committee, Nikal. Because these are the same people who have been advocating for a functional healthcare. And that's why I've seen a different approach to some of these things that we actually have been demanding. And then when you see us not on strike in 2025, it's not because of anything. It's because we are trying to engage to see to it that what are being done about these things that we're demanding, like the employment of healthcare workers. We actually following up to see to it that by June, we have about 2,000 doctors employed. We were actually keen to see that the US-Kenya agreement, what component of it does it have, apart from the issues of data that are being discussed, that are actually going to help the healthcare space and make things work. So the political goodwill, I see it now, because we have there's a continuous engagement, conversations on the prospect of social health authority that is being conversed every day. Yes, it's a conversation that is either there's issues of healthcare workers that is being conversed, that's being discussed. There's an issues of the drugs that the public educated now to know that they need to have drugs in the hospitals. That if they don't have, they bring out into the air. These particular elements that will make healthcare function. The political conversations are there. The president is seen speaking and saying that with this social health authority, you can go to any hospital and get the care you need. That you will be visiting the hospital and get the care. Okay, that's true. The only aspect is, are there enough finances to then pay those who have given the services? Because that's what the problem has not been Kenyans going to the hospital and getting the care. The problem has been that once these services are being provided, is there enough funds that has been appropriated by the parliament that then it's able to pay those who have offered the services?
And the answer is no, Dr. It's no, because people are still going to hospital. People have procedures that they need to then have, but the medical service for which they're fully paid up is not paying. And so people still have to go back to the proverbial harambe, isn't it? People are still raising funds for hospital procedures. People are still raising funds to take care of these bills, even after they've been done. People are still raising funds, and they're fully paid up for SHA. That's the reality of the day.
Thank you. No, that's the progressive reality of the day. Is that, one thing we have to always bring up in conversation is you compare what is there, the amounts that are being appropriated or that are being given or approved in NHIF vis-a-vis those are being approved now. You'll find there's an improvement in that, for sure, in all levels of facilities. And that's what makes many being able to access the care. But the biggest concern that comes in is that the payment of those then who have offered this particular care. Is there enough money that has been appropriated in SHA, for example, in the primary health care to pay all the facilities that have provided the services? Is there enough money that these hospitals then have to be paid on their time? That is the concern that we are raising now, that the parliament need to allocate money commensurate to what the president is declaring, that we are going to have health for everybody. The minister needs to ensure, and the health ministry needs to ensure that actually there's more budget into this health care, because that's what is bringing the problem. Because if we have enough, because contribution-wise, which we have looked into, we have the registered to be about 30 million. But we have those contributed to about 4 million. 4 million. So that brings the burden aspect of it. But how do we ensure there's more money? Is either through ensuring everybody contributes once they have signed up, or ensuring that there's more money from the budgeting?
There was something that was floated, because I hear what you're saying. If you need 30 to then be able to fill the gap and you're receiving 4, it is clear that there's a problem. That you can't expect that somebody else who goes up and they've not paid up, that they would accept care because they would expect care because somebody else has paid up. But then how do you fill the vacuum? But then I think what happens is that there is a need for those in positions of leadership to then be a little bit more creative as to how this money can come. There are people who are not paid up because in their minds they cannot afford it. That we can ask somebody to give 6,000 shillings a year or 7,000 shillings, whatever the case may be, and when you provide them with that number, Dr. you are you're with people every day. You see, when you provide people with that, they tell you absolutely not. I don't have that kind of money. But if you told them that in order for this situation which you're in currently, where you're looking for 500,000 shillings to take care of a hospital bill for your mum or for your brother or for whatever. If I provided you with an option whereby, you know what, you don't have 6,000 shillings today, but you have 20 shillings. Yes, you do. You have 20 shillings that you can put somewhere. And that by a certain period of time, it will gather up into this amount, so that in the event that you need this money for this medical care, you could have it. Do you see the possibility that authority can be a little bit more creative in terms of how we get this money? Because it's little drops that fill the pool. It's not this deluge at once. Is it possible, or am I being too basic about something that perhaps needs a lot more?
Yeah, I think that comes up as an insurance bias, where we see many insurance companies globally having a waiting period once you start paying. If you are going to access services for an insurance, you must pay. Some gives you 3 months to wait, some gives you 6 months, so that you become a continuous payer to access the particular services. And that's what was in NHIF. You used to pay, and then you don't pay and then get the services. You pay and wait. But I don't know, this social aid authority, what happens is that you have not been paying, then you go register, and then you pay.
Yeah.
Now, for example,
and you want service now tomorrow.
And then the services.
In fact, the person is already in hospital.
You're in the hospital, right?
Yeah.
You pay 6,000,
yeah,
and it approves to pay for you 300,000. You see, that's what is happening now. So the advantages of that is that you will access the care. The disadvantages of that is that the fund may not have the money as expected, because you are going to pay, get the care, and then go back home and not pay anymore. And that's what now the aspect of personal, the individuality, the ethic, whatever you need to understand when to get this care. We need to pull the finances, but not everybody will work on that. And that's why when you look at, we went to court against social authority, and now I think we're in court of appeal with other civil societies. One element that the government had put into the social aid authority was that for you to access any public services, death certificate, birth certificate, marriage, and all this, then you had to show the evidence that you are actually paid up. But then we are a democratic country. This was stopped. This was stopped by the courts. And they had to really remove those particular clauses, because I think that was one of the aspirations that they had, that will ensure everybody pays up. But then we have to look at it, that does it conform to the law of the country? Yes. So ideally, that's what we keep saying. There has to be, because for now we have this social authority, that to get the extent, we must all come up and look at what ways will make it work. What ways will make the counties, because for SHA to work, or social authority to work, there has to be hospitals that are operationalized, that are functioning, that will go to the Kuru PGH, that will go to all these hospitals. There are doctors, there are equipments, there are drugs, there are wards that will go, there are theater services that will be offered. So can the counties make these hospitals operational? Then can we then look at what mechanisms do we ensure that there's more funds by the parliamentarians, and also by the contribution?
You know, Dr. One way, and this is unpopular opinion out there, and for a very long time it has been said, fine, there is SHA that people are paying for, contributory, that not everyone who's registered is paying for. But one thing that each and every single Kenyan is paying for is taxes, in one way or the other. In some products, in one way that you purchase it, one way or the other you pay for the taxes. Is it about time that members of parliament picked that up through a proposal, say, from the ministry, to have a portion of the tax, say, even if it's fuel, what everyone purchases, if it's cooking oil, that a portion of taxes from whatever you purchase goes into health? That even the counties can be creative and look at, even if it is cess, a portion of the taxes they collect through cess goes into healthcare to help fund the sector. Is that a creative way? Is it thinking outside the box? Many would say it is increasing taxes, but for healthcare to work in one way or the other, people must pay up.
The model that NHIF used to have was purely the contribution funded.
Yes.
But then you realize that the social authority, they try to combine the two. There is the tax funded aspect of the primary health care. That's why they say you register, and then you can access the care without having to do any contribution. Then there's part of them that is contributory. And that's where now there's the separations based on the benefits that people are able to access. But ideally, even if you look at the Nordic countries and you look even the elder they're trying to bring up in South Africa, when it is purely tax funded, then it reduces the inequality in terms of access. And then it also empowers a functional public health systems. And that has to happen in a place where policies and law are followed, not here whereby people make policies and laws. And this is a reality. The Ministry of Health may be very good in making the policies and the laws and regulations, but do the counties follow the same? I've seen situations where counties are always in harms against these particular policies that are very progressive. So you end up having an effective relation or working environment between the counties and national. And that's why we keep on saying that when we have 48 minds to handle the healthcare, it becomes chaotic. The minister may be as progressive as he is now with the technical team that he has, the Dr. Moth, Dr. Lugan, the entire team, to ensure or forcefully try to deliver the healthcare. But that cannot happen when we have other 47 decisions that have to be made to realize this. Yes, because those becomes the concern. And that's why at the end of the day, we need to evaluate and see what are the gains we've had with devolving healthcare. And are these gains able to make us access the healthcare as we expect in terms of value for the healthcare workers, in terms of the drugs for the patients, in terms of equipment, in terms of service delivery, vis-a-vis what would work better if we change it to this particular system.
So what would work better, and would you then be an advocate for re-centralizing healthcare in Kenya?
I have always been, and because I believe that it's not just a blanket decentralization. We are looking at this component of human resource, because when we have county governments also in charge of or autonomous in some aspect of healthcare, then there's going to be an improvement. When we let counties to be in charge of level 2, 3 to 4, level 2 to 3 facilities, then the aspect of primary healthcare as envisioned within the constitution is actually going to be good, because then these are mostly the primary healthcare services. But from level 3, level 4, 5, 6 ought to be under national government in terms of the human resource component of it. Why? We are seeing that now with the teachers. You see every county, they're trying to see to it that they have the good schools, because everything to do with the TSU, the number of teachers is budgeted centrally. If that happens, then, for example, at level 5 hospitals like Nakuru PGH, the county will be advocating to have this central body give them the right number of doctors and the medicines that they need, because it will not now be a burden of budget on them. It will be a focus on service delivery. And therefore, the issue of budgets will then be a matter of centralized issue. The strikes that we keep on having, and you realize even the clinical officers strike, the aspect is the ministry and the clinical officers have sorted it out. It's just a matter of, it's going to cover 150. But then the counties, none of them has had any engagement to get to ensure they have this CBA. We look at the Salary and Remuneration Commission has given guidelines on the wages that ought to be paid to the workers in 2024, 2025, 2026. And I can tell you, none of these particular guidelines has been followed by the counties, which don't be surprised when you're going to have a strike for doctors, for nurses, for county workers, just to force counties to implement an SRC circular. That's the problem. So you see, that disjointment in action between the counties and national can make national do all humanly possible on one side, but county does exactly something that triggers the action that we're trying to avoid.
Just because they want to, not because they have to. I mean, somebody just decides to not cooperate. That's what we're talking about in terms of service delivery and governance.
Sometimes the Council of Governors is always an activist organization for the rights of the governors, regardless of the situation.
Solidarity.
The solidarity. So, and I saw it when you're having strikes with some counties, you'll see governors gang up together, and even if something is wrong, they think it's right, because they are almost like a union. That's the same way SRC has always a union for the national government. But in that process, some things that ought to be done, like a direction by a Public Service Commission is directly ignored by the Council of Governors on the issue that need to be implemented. So we still believe that for standardization, for better framework of management of promotions, for this payment of state reduction that has failed 13 years down into the devolution, for recruitment of healthcare workers, because now we are speaking about employment of 2,000 doctors by the Ministry of Health. We're not speaking about the employment of 2,000 doctors by the counties, the offices where they work. We were talking about the UHC staff, the 8,000 of them that has been having the issues of wrangle. You will see the finances, the terms and everything has been approved by the ministry. But then you don't see the same effort, the same energy within the counties. So yes, with this disjointed, mega decision maker by many, result in the mess that we see.
There's a lot of work still to be done, but I do appreciate the fact that, Terry, that you talk about there being progression on one side, and that it's to hope that the little needles of progression will actually paint now a bigger picture of getting to the point where progress can be seen and achieved. That's the hope. And of course, with voices like yours to continue in this conversation. Thank you for coming this morning for us to be able to have this, an update, and also then be able to look into what we hope for tomorrow. And hopefully, the sky is looking a little bit brighter.
I think you do, and I hope that the private hospitals that are affected across the country will take this heed correctly and ensure that when they're employing, they employ people with a lot of dignity. And we are saying here correctly that wherever the doctor is, pay them and employ them with dignity. When you engage doctors on locum, because we are going down now we wrote to private facilities across the country last 2 years ago that when you engage any doctor on locum, and the same thing we've told the hospitals, the public hospitals, you engage any doctor on locum, you must pay them as prescribed by a professional body, because these are professionals. They may want to charge hundreds of thousands, but because they've been limited to that 2,000, pay them per hour. If you are to have them at night, pay them that 4,000 an hour. And if you decide on your own rate, then you need to manufacture your own professions. Because the ones that are prescribed by the councils, then ought to be paid as prescribed by the professional body. And that's what we're going down to really campaign on now, this year, to show that every doctor in every facility is given the dignity that they deserve, regardless of the country of origin.
Worth doing. Secretary General of the Kenya Medical Practitioners and Dentists Union is Dr. David Chiatella. He's been here with us this morning. Thank you so much, Dr. Terry. And we look forward to the next discourse with you.
Thank you so much, Ndura. Thank you, Aseto.
Karibu sana.
At 9:02, good morning.
This is the Situation Room, the only way to start your day.